Good afternoon, sir. And this is our good fortune that the past secretaries and founder member of National Neurology Forum, Professor Vinod Kumar Paul, the member Niti Aayog for Child Health and Nutrition, is with us today. And we are going to go back in time and talk about something of the NNF, the National Neurology Forum, of the time when it started, or what was the newborn scenario that time, sir? The idea of knowing our history started when we wanted to look back. What was the newborn health at that time? How did this idea of having an NNF germinate? What was that? When you are the one of those 13 wise men of country who started the National Neurology Forum, your signatures are in the founder member signatures. So please.
I'm very honored, privileged to have you, both of you, and I compliment the team for this initiative of documenting the journey of National Neonatology Forum and how the leadership in neonatal health in our country got built up and delivered in many ways. So thank you very much, a very warm welcome. I was associated with the National Neonatology Forum very intensely. And you're right that I am a founder member. In the year 1981, respected Dr. Santosh Bhargava asked me to be a signatory to the document for registration of the society, namely the National Neonatology Forum. At that time, I was working in Safdarjung Hospital. This is early 1981. Yes, I had that privilege, but the creation of National Neonatology Forum, as we have already gathered, really started with a meeting that was held in Bangalore at some point, late 70s. But in 1980, there was a national symposium on neonatal health, which was truly the precursor of coming together of the neonatology fraternity of the time. This was organized by Dr. I.C. Verma, and I have memories of this event being there. I was busy as a resident, but I did take part in some of the deliberations. So this was the convening where everybody who was involved in neonatology intensely came together, and then this led to a formal establishment of the National Neonatology Forum with Dr. Bhargava as the first president and Dr. D.K. Guha as the first secretary. And the formalization took place, as I said, somewhere in 1981. Those were different days. Neonatology was emerging clearly as a front-runner subspecialty. It was gathering pace, and its need was already being felt because this was the most difficult part of child survival based on the trends that were visible by this time. And you may note that by this time already there was momentum for vaccine preventable diseases. There was some momentum for addressing diarrheal disease, although ORS and other things came a bit later. Certainly, and there was a recognition of addressing pneumonia as well. But clearly, neonatology specialty already being existent in developed nations also got impetus and lessons from there, and therefore specialty as well as the need to promote neonatal survival was by this time very evident. In 1982, minimum perinatal care task force was established. I think that was a landmark development. It was the first convening in which formally contours of neonatal care were being talked about. Of course, linked to obstetric and the motherhood care. So it was minimum perinatal care, and rightly so. But that was the first deep thinking on addressing neonatal survival and neonatal health. And this was a blue book. The recommendations were relevant at the time, and it talked about regionalized approach to newborn health, etc., perinatal health, etc. So at that time, the picture was very different. In 1980, the neonatal mortality was around 70. 1990, it was about 53. Currently, 2020, we are at 20 per thousand live births. So it's been a long journey. It's been a difficult journey. It's been a journey which had to be delivered in terms of action and changes on the ground, systematically, intervention by intervention, package by package. But we're happy that we have a situation now where we believe our SDG indicator, namely NMR of 12, and our own goal of single digit NMR by 2030 is within our grasp.
Amen.
Indeed, yes. And already urban India has achieved 12 NMR in 2020. 6 states have achieved 12 NMR already, and 4 other states must have already achieved it by this year.
So this passion which you are kind of was evident in all the people we have talked so far also, and the passion of it was unsurmountable. The number of deaths, the figures you are telling about, Dr. Bhargav was telling something about 100 of NMR in this time when he was started in 60s or 60s or so, and from there coming to 20 and targeting 12. This has been the fruits of the hard work, labor, the dedication and passion of the group which started there. Did the group ever truly believe? Because they said, yes, we believe in that. And the good people from that time, whether it was Merchant, Sir Merchant, or Dr. Rajaram, or Dr. Timin Irani from that part, and other people from there, were they all different kind of people who had a different passion inside? What was the idea and the notion and the excitement and enthusiasm when you started this? Or there was subdued kind of pessimism?
So I told you that there were 2 strands which we must recognize. One, that the speciality of neonatology should bloom systematically, because this speciality was well established in developed nations and we had to catch up, and we were getting to find the pathways and resources and connects and exchange of ideas on that sphere. So we must not forget that ultimately neonatology fraternity is about a specialty dealing with very, very vulnerable, very special children, very special citizens of India. So that creates a bond for all of us to work together, because we on a daily basis practice delivery of healthcare in our own settings. So we needed to learn from each other. There was a zeal to learn from each other, learn to do better, learn to do more science, connect with nursing care, connect with evidence-based intervention, connect with intensive care, and learn to do. So this was our core day-to-day work. And then, by extension, not only was the passion to not only expand on this, to excel in this, but then the wisdom of our group was that from almost the very beginning, the larger context was always in front of us. We as a group, and I'm only a beneficiary of this because this really started with one generation higher than us, the likes of Dr. Mirban Singh, Dr. Bhargav, Dr. Baku, Semin, and others. Those are the revered names. I salute them. I pay my tribute to them. They were my teacher, the teachers to so many of us. So they had already set their sights on the big picture. So it wasn't only about healthcare, but that must not be divorced. The point I wish to make it happened because we were doing that business on a daily basis in our professional life. But then we were different from others, that very early in our own journey of excellence, we recognized the need for this to be in the context of the bigger picture and to deliver adapted form of newborn care down to the secondary level, to the primary level, and this is how we do it. In fact, it is true to an extent for as pediatricians also, because by habit we start to think about of public health prevention. But since we are focused on the journey of neonatal health, clearly these leaders had shown us the path that not only you practice great neonatology and science and art of neonatology, but also think about how to improve neonatal survival and improve neonatal survival with high quality outcome from the very beginning. So the passion was to make a difference to the to excel in the science and art, but also to take this to scale and make a difference at the national level.
So you have to ask.
Yeah,
you just
yeah.
keep listening to him only. But
I'm just
like a good
mesmerized by the
student.
story.
Like a good
So from the inception, I was just wondering how did it expand into a formative structure kind of thing with collaborations with other fraternal organizations like the gynecologists, our colleagues, and the pediatricians.
So we were different.
Hmm.
I'll tell you that we were different. You may not perhaps have been told, I guess, that in the initial phase, you had to qualify to become a member of the National Neonatology. You had to justify.
Okay.
You would give your CV, and then the executive will think. Yes, that's how we started, and for I would say several years. Then there was a need to make it into more like a movement, and then it was eased up. But the initial phase was that you justify that you want to be part of this esteemed group because we started with a mission. I told you the twofold mission: speciality and the public health cause. And you are committed in working with the value system that our leadership had set forth. So we were different. NNF was different from the beginning. It had challenges because the other
In
organizations.
fact, the name forum was so different from all other
It was
organizations.
different because
it was purposely kept.
we had humility that we have a larger body of pediatricians and we respect that. We are an offshoot with special focus in one area, and we are a forum, of course, technically a society like other societies, but we were more like discussion, debate, taking forward the larger agenda, the science agenda,
The
and so on.
advocates.
So we positioned ourselves differently, and we worked differently. our work हमारे काम की शैली जो थी जो बाहर और एसोसिएशन है उनसे बहुत अलग होती थी. For example, from the very beginning, to work with the obstetrician was a dharma, a fundamental principle. You may have been told that for some period of time, it was decided in my time, during my secretaryship, that alternate annual events of Neonatal Forum will be in partnership with ISOPAR.
I
Indian
have
Society.
seen the photograph.
Yes. So it was decided that we'll have a joint event this year led by NNF but with ISOPAR. Next time it will be ISOPAR, joint event with NNF and led by ISOPAR. So that's how we will do it alternately. So this connect was there. And very, very early in the course, our commitment to work and promote and to improve nursing care and neonatal nursing science and art was also in our DNA. We were different in that regard. Likewise, because technology was important to us.
Yes.
From the very beginning, we were mindful of creating made in India technologies.
Yes.
Now looking back, I know that it was all made in India effort, and from the very beginning. So an engagement outside the immediate profession
Industry
was also a part
think,
of,
in fact, one of the
particularly in those years.
industry was a part of members also.
They were made members from the very beginning. That whoever is associated with neonatal care activities will be made part.
In fact, the earlier publications, the earliest ones are on the survey about the equipment's availability
right.
in the various units across India. I think
That's right. I'll come to that because we wrote a few documents and summarize them. But we were different, and we created our difference because we, as I said from the very beginning, had a passion to make a difference on scale.
You
And
said
a passion
one word.
to excel in science and art. Both.
You said one word, systematic, sir. So please just guide us, the younger
So
or future generation.
I can.
How did you go about
Yeah.
and what's the major initiatives which actually brought NNF to this platform today?
So when I became joint secretary, that was the formal and deep association, almost like much of the time, in a daily routine. 1989 to 91, I was joint secretary, and next 2 years, 91, 93, I was secretary of the forum. Now here is our team. I had Dr. Sudarshan Kumariji as my secretary, and at that time, Dr. Mehban Singh was the president. When I was secretary, my distinguished friend Dr. Ramji was my joint secretary, and esteemed Dr. D.K. Guha sir was my secretary. So whatever I would, share with you in terms of the activity that you asked, collectively I would say these 5 people, because we were all doing it together. So it is in that period, and of course, respective colleagues will have their own contributions beyond or before this time. If I club the work, so let me say that at that time, as you heard from me, that we were thinking about the big picture, thinking about standard, we were thinking about training, and therefore one major part that happened in these 4 years by the team, but by Rajya Neonatology and NNF Fraternity, was reports and monographs.
Yes.
So here is a list of 6 monographs at least that I can recall. So and this was a very systematic approach. This was being done in a very serious manner. Meetings would be held, brainstorming would happen, report would be written, report would be released.
So in fact, we wanted to know what are the policy documents you are just.
You can call them policy document, because some are policy, some are related to the overall nurture of the neonatology. So we had primary care of the newborn, which was actually steered by Dr. Sir Bakku in 1981. We had neonatal nomenclature and data collection, because even the nomenclature
was not right.
was confusing at the time. SGA or SFD, what definition, it was a big issue, and how to collect data. So we were also different because we would talk about data, talk about analysis, talk about advocacy, which is based on ground up information. So we had this booklet called Neonatal Nomenclature and Data Collection. Dr. Bakku was also at that time in the transition associated with this. And we had a document called Education and Training in Neonatal Nursing, and Manju Vatsa and Dr. Guha and Dr. Mehban Singh, we all did this, and of course, Neonatology Forum did it. We had a monograph on biomedical equipment.
Yes.
Status and perspective. This was the year 1990.
Yes, biomedical.
Ashok, myself,
Yes,
Dr. Mehban Singh, we conducted this workshop and then wrote this up. People who are in neonatal biomedical devices area say that this is was very critical, because through this we started a systematic process of engaging the industry to make affordable equipment available. Let everybody know that neonatal care, even at that time, needed equipment, weighing scale, open care system, incubator, ambu bag, resuscitation system, need phototherapy unit. And you may have been told that we would improvise with having tube lights, babies. Sure. Everybody was trying to improvise. We didn't have more much. So this pain was translated into a systematic study of where we were with regard to equipment, who was making it, and you refer to a survey that was conducted. We sat down with the policy makers, we sat down with the industry in the year 1990 and looked at the pathways to make equipment available, affording the cost, but also how to encourage that. And we followed the philosophy that we will buy Indian equipment. This was something which was very, very special to all of us, not only because it was affordable, but also because we wanted to make the point. So at AIMS, we chose actively and proactively to acquire made in India equipment by these people. And I would say I'm happy to have 20 ambassador cars than having half of Mercedes,
Mercedes.
because we believe in this.
Yeah, we
So
heard that on
biomedical
rounds also
equipment,
a lot of
yeah,
times.
and then there was a fourth monograph was on communication strategy for the care of the newborn.
Okay.
Dr. Chatterjee, Dr. Dilip Chatterjee, Dr. Vani, Dibakprat Chatterjee, sorry, Dr. Vani, Dr. Bhargav, Dr. Guha. This group steered, and I had the opportunity to work on this. The whole idea was that we thought we need to make a stronger case for newborn survival. To the policymakers, to the people in general,
Yes.
how do you work for? So we knew that advertising agencies have pathways of communicating, convincing, selling their products. So with the help through Dr. Chatterjee, we actually had engaged at that time in Kolkata a very leading advertising agency who sat down with us and showed us how such a strategy can be done.
So, well, looking back at
And also the last one, the sixth one that I'm recalling in those 4 years of time, was traditional practices in newborn care, which was steered by Dr. Vani, and a workshop was done in 1991 in Ahmedabad. So these six documents were, can say, policy and think tank documents in a way, which help the respective causes, and this was one of the major activities.
How did these NNF documents get converted to a national policy? How did you approach the government of India? Through meetings, through data? What worked for organizations?
how did the government
collaborate with
with
NNF? Because we feel that maybe we need to work upon that domain yet.
Today it is very simple. You are sitting in India, your
So,
doors
but
are
we need to
open
have
to the
strong movement
government.
down
That time
culture.
it wasn't the case.
Yes. So
Okay, if you go in that direction, I want you to appreciate one aspect. By late 80s, early 90s, child survival efforts had already undergone a very major shift. From just focus on immunization, there was a clear focus on diarrheal disease control and reduction in mortality. So this was the big one.
okay.
That now we had a new tool, diarrhea mortality, which was about 25% of child mortality, let's say. We could address it. And almost a couple of years thereafter, so 90, already we were thinking about pneumonia control program, the ARI control program. So Dr. Vijay Kumar and Dr. V.N.S. Walia and others and WHO, the algorithms for treating pneumonia in systematic way was already being talked about, other than vaccine preventable pneumonia. So already there was a push for vaccines, push for diarrheal disease, and people in this field were really trailblazing, going all over. Pneumonia was picking up. And along with this, there was a movement for breastfeeding already taking place. Now, we had the challenge of positioning newborn care into
Yes.
all this.
And
Yeah.
we had
How, sir? What
we
works?
had
How should we
inferiority
convince
complex
you?
at the time because
Yes.
for us it was very difficult to communicate that you need antenatal care, you need delivery, that you need bombs, you need antibiotics, you need and so on, and small babies, and also difficult discourse because these conditions were single diseases.
Yes.
When we deal with neonatal health, we have at least
Yeah,
4
package.
major diseases:
Yes.
asphyxia, infection, low birth
The
weight,
pillars which we
and
call. Yeah.
and the birth defects.
Birth
So we're dealing with more complex situation. Nonetheless, what was already very visible was that neonatal mortality, the first month mortality, was a major chunk.
Contributing to it.
At that time, it was half, and then it was rising as a
Rising.
proportion of under 5 mortality, and it was very visible. And therefore, we had the confidence, we had the rationale, and we had the epidemiology backing us to do things for the newborn. Now, what led from first step to the next step to the other steps, you would say in that period, because the journey then continued in different ways, would be starting with a minimum perinatal care meeting, engagement. So we're talking about how to go about doing neonatal care, focus on neonatal tetanus in particular was already
Neonatal
there,
tetanus, yeah.
and so on. But the clarity as to how the full package should be was really not evident. We didn't have, developing country models. The model that existed at that time was really the developed nation model, the intensive care programs, still, skilled birth attendants, etc. But what happened step by step, it didn't happen overnight, was that when the neonatology forum would do this advocacy, we will get traction. But then I think we got traction and recognition with the resuscitation program.
This is what actually I wanted to do, because 89 is the time, watershed movement in your tenure, when the neonatal movement started.
So that created a buzz.
Okay.
At that time, as you know, that we were calling it neonatal advanced life support program. The fascinating thing about NELS and now NRP is that it picked up on a very major cause of perinatal neonatal death. And its training program was interactive, was using a set of simulators. Training based on the American Academy of Pediatrics program was interactive, very scientific, very impressive, very structured, and we embraced it completely. Now, when these trainings were going on, there was a buzz. People noticed the neonatology fraternity and NNF, and that gave us visibility. So let me just go back as to how NALS happened. NALS happened because in the year 89 or 88, AAP came out with this NALS program corresponding to the pediatric life support and of course adult life support programs in that country. I had the opportunity to be in Chicago at that particular time under the guidance of Dr. Vidyasagar, informal fellowship of sort on my own, and with the blessing and the support of Dr. Bhutani and Dr. Sagar. Courses of this nature were starting to be conducted there. And Dr. Vidyasagar said, "You join." So I joined the course. I got perfect score. And I was wondering, because it was so fascinating. And then
you stayed with him, it seems.
Then, a flash, why don't we take it on scale to India? So sitting in the cafeteria in Dr. Vidyasagar's hospital, University of Illinois, we did a plan on the paper napkin. We decided that we'll take it to scale, and because I was official of Neonatal Forum at that time, so I could say that we can do it. So we worked out. So the same model of trainers and then training workshops, certification, structured information to be delivered, etc. was thought about. And then later that year, the 5 overseas faculty led by Dr. Sagar, they came to Manipal, and we had the first workshop of national faculty. This was followed by 2 more. Ultimately, we had 150 national faculty created in the phase that I was associated directly, and then many more. So that's how it picked up. And they brought 1 mannequin each. So we had
100, more than 100?
No, they brought only 1 mannequin each, 5. So this large nation had 5 mannequins and 5 sets of resuscitation bags and other equipment available to us to conduct this program in the entire country. So we started 5 mannequins.
So how was it taken up?
So 5 sets.
5 sets.
5 sets.
Yeah.
And we were very proud. And we said, okay, there will be a regional system. So 1 set resuscitation kit got allotted to each region. We had regional faculty coordinators. This great nation, large nation became, subdivided into 5 regional systems, regional faculty, led by a coordinator. And we started the job. And what was good about this training program was this being interactive. This was crazy. The reception was crazy. The residents, the pediatricians, the nurses, they would just flock and they give us great reviews. We will take our feedback. Started with these 5 sets of equipment and 5 teams, and started to start conducting these workshops through their own respective resources. But then we were fortunate that the government of India gave us a grant. I think it was just about 2 lakhs or 2.5 lakhs grant, with which we purchased a few more mannequins, and we committed to conduct many workshops, and in an attempt to try to really create a true buzz and saturate different areas, saturate in its own modest way at that time. So up into between 90 and 93 or so, 220 workshops, 220 with a little 2 lakh rupees and whatever other resources. By this time, we had 150 national faculty and 12,000 trainees were imparted training.
And it was supposed to be tough
12,000.
training to pass.
Pratima, we have to do
No,
we have to
12,000.
match
It
it
was
number.
not like a blitz, and this got noticed by the government.
Okay.
So they saw that here is a group which means hard work,
Yes, the
and
credibility.
here is a group which is is passionate about promoting newborn health, and also it gave us a very precise path for us to
Okay.
move forward. As I said, we deal with infection, prematurity, low birth weight, feeding. So this said, okay, isse shuru kar. So this sort of got disseminated. Then the inflection point happened when child survival and safe
CSF.
program was
92?
crafted, 1992. At that time, since all for multiple ways the government was hearing, there was positive buzz around it. Other stakeholders were also appreciating this work. So at that time, and we had some ideas on how to go forward. This was only a part. We had ideas on care of the low birth weight. We had ideas on how to treat sepsis. We had ideas on referral. We had ideas on feeding, etc. So putting that all together, then essentially one component got incorporated into CSSM program. The child component of which already had immunization, diarrheal disease, and ARI program. So this became the 4th sub pillar, and then this was scaled up as a district newborn program in about 29 odd districts, and that was the start of how increasingly the newborn care became part and parcel of a child survival program, got into RCH program. Later on, eventually 2 pillars became very visible, namely the facility-based newborn care, and then also the home-based newborn care, and so on. So the break happened because neonatal fraternity, neonatal care fraternity, the National Neonatology Forum, through its systematic approach, had done a disruptive work to bring forth the need to focus on newborn health, have ideas on how to address neonatal care, and also to demonstrate that a very major, responsible, structured effort in training can be instituted.
And that reaped the benefits because our neonatal deaths started falling down, and actually the IMR started falling with the impetus on the asphyxia management also.
Well, it started with that. Asphyxia deaths are more difficult to change. The deaths due to moderate low birth weight, for example, are easy to prevent because they need gentle care and warmth. Sepsis deaths also getting to be addressed. But surely it was all-out effort, and mild asphyxia responds so well to resuscitation efforts.
So 2 more things happened around your time. 89, when I was looking back at things, 90 accreditation movement started in NNF. And the first document probably came around 1991.
Dr. Sudarshan Kumari was already working when I chipped in, but the completion happened, completion of the document and the criteria was finalized when I started to work, joint secretary for her. And yes, it was started at that time, accreditation level to level 3 accreditation system was instituted here, right? And then it also showed, when you look at why people would start to listen to us, because we talked about standards, we talked about,
So we were way ahead of the West
rating,
also. Best
accreditation.
also. In accreditation, we went ahead of the West also.
Absolutely. In a way, many ways. And this was not the usual, professional body trying to do advocacy. We were already thinking about the standard because our leadership had already showed us the path, and we were drawing upon the experience in centers of excellence, better of centers, to be able to for others to emulate. So this was helpful. Another activity that happened at that time was National Neonatology Neonatal Perinatal Database. National Neonatal Perinatal Database, which the idea was that we will look at, we talked about nomenclature and data collection.
Yes.
So a natural extension of that was that we will collect it. We will look at survival. We will look at problems of different gestation and weight age groups and so on, and our practices. So through this came the initiative National Neonatal Perinatal Database. Was the first version, there was a second version, and then there was a third version. But the first one was done at this time. I think at that time we involved 14 top institutions, 12 to 14 top institutions. And one of the key learning, which is even for which again Neonatal Forum, National Neonatology Forum's work can be given due credit, is that we, in our own way, flagged antimicrobial resistance as a very big issue. One thing which became very obvious was that Klebsiella was the king. The standard teaching at that time was, the GBS and other infections in the standard textbook, which were not there. But we needed to show with data that this is not the etiology. E. coli is not the etiology. Staph aureus to an extent. But Klebsiella was increasingly dominating the picture. And Klebsiella has been our enemy for long. And now, of course, we have many more enemies that time. But the NNF's role was to collect, to be transparent in terms of creating an environment of teaching all of us that we should be transparent about sharing practices, problems, epidemiology, and the outcomes, and learn from that, and then create pathways to improve. And that, again, really made us different from others.
That brings me to the next question, sir. What do you see the main challenges? What I see is that sustaining the credibility of the organization. How do we do that? I mean, somewhere down the lane, maybe there is a dent in the credibility, or somewhere there is a low phase for an organization. How do you bring it up from that phase? And secondly, the organization being such a big organization is a heterogeneous, forum. We have practitioners.
इसको ना edit out करो because
it takes a lot.
रिटर्न में आएगा credibility क्यों करनी पड़ती है? ठीक है, वो मैं कहीं तुम मुझे लेक्चर दिलाना फिर अच्छी तरह से समझाऊंगा मैं. ठीक है, इधर जाते ही है ना. मैं बताता हूँ इसमें जाने का मैं बताऊंगा बाद में. ठीक है, इसके ऊपर बाद में रोल आउट करने में जनरल हम बात कर सकते हैं. I think I would like to add, अपना ऑर्गेनाइजेशनल के और कुछ पूछ लो. एक्सचेंज प्रोग्राम स्टेट ब्रांचेस, ये मैं थोड़ा सा कवर करना चाहूँगा.
Sir, actually I wanted to know the other personality from you. The personality like Dr. P.K. Mishra, Dr. Marchand, Dr. Shashivani, Dr. Siman Irani, Dr. Sudarshan Kumari, Dr. Guha, Dr. Baku, Dr. Bhutani, Dr. Vidyasagar, the kinds of name which people want to know from how did you see them? How did you see them as role models? And how did they inspire you? As you said, you revere them, they are teachers to you. But for other younger people, you have to tell us some anecdotes or some good things about each of them.
Well, I would like to salute all the revered names that you listed just now. I had a very intense association with, of course, Professor Nirmal Singh, who's been my mentor, role model, guide, philosopher. I also had a working opportunity with Dr. Bhargav, who actually sort of, excited me and motivated me and influenced me, inspired me for thinking at the big picture, because he was at the forefront of looking at how the public health, mental health should be thought of as an activist as well as a
You got the opportunity to work with Shantikot Madam?
No, I did. She had already superannuated. So Madam Shanti Ghosh, Dr. Merchant, no, I missed working with them. But I had a wonderful relationship with Professor Bakul. Long discussions, talks, inspiring words from time to time. So, and then of course Dr. Guha, with whom I was actually his deputy in this court, the course of time, and intense interaction and guidance from him. I also worked very closely with Dr. Shashivani because she was so proactive in many ways. I talked about traditional.
She
newborn
championed some
care.
rural.
She championed that. She championed kangaroo mother care.
Mm.
She's the mother of kangaroo mother care in India. She would come several times. We worked and did workshops, not only resuscitation workshops, but also ventilation workshops and anything, and at multiple workshops I gone to Ahmedabad and Gujarat. Simran ma'am has been very special. Hamida ma'am has been very special. Late Dr. Jayam had great affection for me. So this was the cohort, Dr. Narang later on, and so on. This was the cohort. Sorry if I missed any name, but this was the cohort of my seniors from whom I drew inspiration and knowledge, values, and and the zeal to work. And then of course in my work, Dr. Sudarshan Kumari, Dr. Ramji, and then of course within the department, Dr. Ashok Tiwari and me, we worked almost like two sides of the same coin, working. Everything that I did, the internal support was always available, and beyond this period as well. So we have a wonderful group of people to have worked with. That's why we were different, and there was a cause to follow. There was a mission to follow, and that aligned us to policy products, training products. By the way, during that time, there was the second exchange program, Indo-US program.
This is actually
Also, which National Neonatology Forum
International exchange.
coordinated. The first one happened before this when Dr. Nirvan Singh, Dr. Bakku and others had gone. But the second batch, was coordinated in our times. But also, interestingly, we brought in the Indian version, in-country version of the exchange program, which means we would identify through application people who are working in centers, different centers in the country, and bring them to centers of excellence for training. And this was again funded by the government. Very modest money partly was available. So people came to AIMS for working for 4 weeks or so, I think. Some others went to different places, PGI and other places where such services were available. So we had this mirror intra-country exchange program that was also instituted at that time.
I'm a beneficiary of it.
You were beneficiary. You came.
Came to him for 1 year. And
We also started state branches, by the way. In these 4 years, I don't know which particular year,
Okay.
but the state branch movement
that started
was
in
also
here.
started. Yeah. But
Oh.
that was the other thing. So I wrote the charter for
The state branch.
how the state branches should be established, what should be their expectation. For example, we said your accounts and our accounts are separate. There will never be any connect between the two accounts. And then, of course, it was improved upon by the executive.
So the Indian diaspora helped you talked about. Was there some international collaborations other than the Indian diaspora? The Indian diaspora had a major role in bringing good quality, high-end, advanced neonatal care to in India. Some of them took our students, some of you abroad also, like in Canada, in US, or in Australia.
There has been an amazing contribution by Indian neonatologists abroad. Without them, our journey would have been difficult and delayed, and perhaps weak, at least for some period of time of late 80s and 90s. we could have caught up later, but then they came at the right time. And again, they came because they saw people. National Neonatology Forum, the group and the fraternity was so focused on trying to do positive things. So the connect happened. It was, the US side was totally essential and eminently led by Dr. Vidyasagar, who around him then had wonderful people, such as Dr. Vinod Bhutani and Dr. Siva Subramanian and several others, Dr. R, from his own team, and so on. I think we should all chronicle all their names into the put up scroll, those who have helped from time to time. Their names can be found in the NNF annual meeting programs so that we have a more complete list. So it helped. Dr. Elizabeth John from Australia Westmead was helpful. We also got support from UK to an extent. So this was a very major support. And as you said, some of us were very direct beneficiaries. We have talked about 2 exchange programs in which almost 30 people had gone there, the senior leadership. They had gone there, they lived there for about 4 to 6 weeks. They observed, they didn't actually practice neonatology there, but they observed. I had a separate opportunity to be there for 3 months. And then, of course, I also had a WHO fellowship.
I've seen your notes which you have kept.
Yeah.
When you
They were amazing teachers. They understood the India context. They adapted their teaching, their messages to us in the right context. But they improved the science for us. I think the way we do or did things at that time were more practice, more art, but a lot of science. But then they taught us to put more science in the art as well. So pulmonary physiology, decision making based on blood gas values, and so on and so forth. Brain physiology, pulmonary physiology, cardiac physiology.
Those are the conferences.
In a way, amazing way. So I salute our overseas teachers, colleagues, and we are the nation is indebted.
So the young people like Pratibha and us who have not been fortunate to have seen those era, and for the benefit of those who will come in the years ahead and the generation forward, there has to be some good words for what is the way, some key messages, or what will keep us going together towards the goal of actually having the lowest neonatal mortality or the you say intact survival of newborns, which you so fondly tell us all the time. The message.
Well,
Right. Start, Karan?
Yes, sir.
Battery, the light on? For the young person.
So for neonatal care and the subspecialty of neonatology, my request to the young pediatrician, neonatologists, and neonatal nursing and neonatal teams is that adhere to the highest standards of care. We were in an era where we didn't have optimum resources. We were learning, but today, for India that aspires to be a developed nation, from now, commit yourself to deliver newborn care of the highest standard. Care which is based on standard treatment guidelines. Care which is holistic. Care which conforms to the protocol. And care that is humane, involving the family. And it's family centered. And it is centered around the overall intact survival of the baby. Work as teams. You alone are not enough. We all need to be a part of a team. Use science, continue to improve your caliber in terms of scientific decision making, as well as the art of delivering newborn care. More than any other discipline, neonatology is a great mix of science and art together. And it's a good fortune that we are in this space. That's one. Second, in terms of going further, going into future, we should have strong research.
Mm.
We are still, we have a lot still to cover in terms of our journey for highest quality research. We should be in the forefront, at the forefront. Research that on one hand is public health, clinical, on the other hand, basic science and translational, and also solutions, technological solutions. The AI is looming large. We need more efficient devices, care devices for babies, and so on. So I think the holistic R&D, innovation, digital solutions ecosystem, be master of this. Let people not lead you. You lead the world.
Yes.
And India's destiny is to lead the world. That's my second request to you. My third request to you is that we are aiming for absolute normal and intact outcomes. We have, and that's an important part, and it must be stated, it's really not covered in the first point. We were tasked to ensure as much as possible survival. This was our challenge in our time, in the time of our leadership. We, to a large extent, have been successful and increasingly
Very
successful. When we talked about intact survival, we would say no major brain damage, no more acceptable. We will not accept any brain damage. That should be our goal. But should we have a truly intact survival in the fullest sense? But what we have ignored is nutrition outcomes. I'm very concerned that the nutrition outcomes of neonatal ICU centers, graduates, SNCUs, etc., are really suboptimal. Part of it is not easily changeable. Part of it requires research and solutions and protocols and interventions, but part of it is something that somehow we, at times, may not be doing optimally. So nutritional outcomes without pushing the baby on the overnutrition side, but optimum nutritional outcomes, I think is a challenge. It is special to us because we have, growth restricted babies as a significant proportion as our clients in a big way. Connected to that is that when we follow up these babies, we must ensure not only again continuing optimum nutrition, but also continuing developmental nurture, positive nurture. Because if you don't do positive nurture and it is left to the family, that may not necessarily be the optimum outcome. We are looking at losing no IQ point or social quotient point whatsoever. Time has come that, of course, we have the development center intra-nursery care, which is now mainstream and must be intensified. But when the baby goes home, we need to enable families so that they ensure that the child's development, in here, development really means connections, synapses, and so on and so forth, is taken care of. This is to ensure that not only we are picking up babies who have problems, but ensuring that babies move on the path of absolutely optimum outcome. Actually, the same thing applies to nutrition. We're very happy to look at a baby who's an infant who is severe malnutrition and then start to do things. But what about preventing and averting that? It should not happen. There should be no child, no infant with SAD. Likewise, as much as possible, we must make sure that we give the second opportunity to the baby postnatally and in the home setting for optimum outcomes, so that the touch, the sensory outcome, the motor, sensory stimulation, the motor stimulation, the speech and the sound and the music and so on, all this should be a part. And I think India can really create our own model. Our fraternity should create them. So these are my three expectations professionally. On the policy front, we have all the pieces now of newborn health and newborn care in the national program. There's nothing is really missing. What are the building blocks? So you have care of the mother, quality care at the time of delivery, and more you bring care of the mother in picture, more of elements of care intrapartum and immediate thereafter, better outcomes we will experience for our babies. But then for the domain that we are dealing with directly, we have facility-based care, we have a home-based care, and we have the enablers such as the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, which provides assured treatment and care for families and babies of the families of half of India. Please appreciate what is available to babies today. Cashless access to care, secondary and tertiary care for newborns is available for babies belonging to half of India's population, both in the public sector indeed, but here public sector also gets additional resources for those packages, but also in the private sector, which is what PMJ has done. So more avenues are available, and this to me is something so very opportune. We must make use of this very important demand side assurance available to the children of India. Please make sure that families know about it, families access this, and we have the large body of hospitals providing newborn care, public sector, but also in the private sector. All of you who have neonatal care in the private sector, please be part of PMJ if you're not. And if you are, please tell others to become part of established newborn care facilities there, because together we can provide enough supply side for the care of newborns. We are at that stage. These are my humble submissions. Never forget the care based on involvement of the mother, kangaroo mother care, which is another story that the National Neonatology Forum has steered. It happened later in our lives, not in the period that we are discussing today, but some other day we'll talk about kangaroo mother care, care which is based on breastfeeding and breast milk feeding, care which is based on prevention of infection with good practices, care which is based on rational use of antibiotics, care which is based on nurture, teamwork, and good feelings. Thank you.
Thank you.
Thank you. All the best.
Phoenix. Enabling life.